Dr. Partha Ray, if someone was to ask you what it is that you do, what would you say?
I would usually introduce myself as a cancer surgeon. I finished medical training at MCP Hahnemann School of Medicine, that's in Philadelphia, Pennsylvania, in the United States. Then went on to do 6 years of general surgery training at Robert Wood Johnson University Hospital, that's in New Brunswick, New Jersey. And because I grew increasingly interested to cancer, I pursued additional fellowship training for 2 years in surgical oncology, and that was at the John Wayne Cancer Institute in Santa Monica, California, prior to assuming my current responsibility at the University of Illinois.
So tell us a little bit about 3N Diagnostics. So what is it and what do you do with 3N?
3N Diagnostics is a company here in Belfast, Northern Ireland. It is the second company, the first one being Onconostic Technologies, that's based in the United States as a more an R&D company. Both of these companies are essentially in the process of commercializing a novel finding that arose in my laboratory that deals with a novel biomarker or test to identify a very aggressive form of breast cancer that otherwise eludes diagnosis.
And that is basal-like breast cancer?
Yes, it's a basal-like breast cancer. This is an entity that we didn't even know existed until the human genome was decoded in the year 2000. Subsequent to that, our molecular understanding of cancers in general, but definitely breast cancer, has expanded to include an understanding that there are very distinct types of breast cancer that behave very differently in terms of who they affect, how aggressive a course they manifest, and yet may look identical to the pathologist under the microscope. And so without this type of definitive molecular level test, we really wouldn't have any way of diagnosing any distinct group, but definitely not this really aggressive group that's called basal-like breast cancer.
And so our understanding has shifted. Cancer is really a catch-all term, but even within breast cancer, we're talking now about different types of breast cancer.
Certainly. So, you know, as we began our understanding in general in the field about cancer, and this dates back obviously hundreds of years, but in the modern era really more about 100 years or so, we attempted to systematically improve our understanding by staging the degree to which a cancer had already advanced at the time of diagnosis. So we term that cancer staging, and many international bodies recommend staging criteria by which we get an understanding of how far gone or how far advanced is a certain person's cancer already at the time of diagnosis. You know, we often hear stage 1 or stage 4. That's where that term comes from. And the reason that is so important is that this is a unifying definition the world over. No matter where a patient might be in the world, when we talk to colleagues or one another about cancer, when we qualify that statement by talking in terms of stage, we get a sense that we're talking about equivalent disease, caught early or caught mid-development or unfortunately caught late sometimes. That definition has served us well for almost 80 to 100 years because we obviously understood that if we catch something early, we're going to have a much better chance at curing that person. But if we catch something late, we're going to have a much lower chance of that. And so in our initial therapies, we're just targeted to decreasing the stage or acting more aggressively to stop division of the cancer cells when we do catch it at later stages. So we clearly have come very far from that beginning time. The problem is that existing therapies have reached the limit of imparting benefit. And really we were not going anywhere until we had this further advance. So it's not just enough to know about the stage of the breast cancer anymore. This new understanding reveals that what we have been terming breast cancer, it's almost an umbrella term for almost three very distinct diseases. And we refer to these now as molecular subtypes of breast cancer. They're not just different based on these markers that we test for in the tissue. They are very different in terms of the age and race and ethnicity profile of who they afflict. They're very different in how rapidly they grow or how rapidly they spread or metastasize. They therefore, logically, should be very different in how they should be attacked therapeutically. And luckily, that hunch is proving to be very true. There are identifiable discrete targets in each of these that are not shared across the board, but are unique and distinct in each one. And the only way to improve our success rates towards cure for everyone with breast cancer is really to approach it as distinct subtypes of disease that demand distinct treatment paradigms. A big part of that is tailoring the treatment in a very precision-minded manner, tailoring it for the patient, personalizing how we deliver cancer care. And this is a strong enabler of why we think this is distinctly possible in our lifetime.
How common is basal-like breast cancer?
Currently, basal-like breast cancer does not have a good way of being diagnosed, and therefore definitely does not have any tailored therapy available. Obviously, we need to be able to identify a set of patients accurately first before we can design, more tailored therapy for that type of person. We do have a battery of tests that pathologists will run on tissue that has already been proven to be a breast cancer, like on a biopsy, prior to undertaking care. Those battery of tests definitely give us an idea about whether somebody is likely to have basal-like. There are other more advanced research tests that would be more exact. But unfortunately, it's a very expensive undertaking, and these expensive tests also have not been necessarily validated enough. So unfortunately, since we're not in a position yet to accurately identify this group all of the time, we're treating them the next best way, which is treat them as an aggressive subtype, or we think somebody has aggressive breast cancer, but we're in no position to tailor therapy for them yet.
So what's different or new about the Avisio test kit that 3NDX has developed?
The Avisio biomarker kit, based on the detection of the FOXC1 gene, it's actually fork-head box C1, which is a transcription factor protein. Transcription factors are genes that play a very central regulatory role in gene networks in any cell, but definitely a cancer cell, and coordinate the activity of hundreds of genes at a time. With very minimal changes within its own level, it can exact very wide-ranging differences in the levels of other genes, and therefore is able to exert very profound effects on cell structure, but also function. So this transcription factor that we've discovered from our research plays an extremely important role in driving aggressive behavior in cancer cells, definitely basal-like breast cancer cells. In fact, it almost imparts the property to the cell such that it is almost specialized for spread or metastases from the very beginning, without necessarily having to adapt to its environment and then spread. This is one reason why these tumors can be very small, do not clinically demonstrate any spread to the regional lymph nodes or anything like that, and yet have already metastasized via the bloodstream to distant organs that eludes detection until it's too late. So this kit will allow the very accurate detection of FOXC1 in the breast cancer tissue, precisely and accurately, so that we're not going to underdiagnose patients with basal-like breast cancer, but definitely not overdiagnose either. Because this test will enable accurate diagnoses of patients with baseline breast cancer. It will enable us to treat them more aggressively up front instead of missing that diagnosis until it's too late.
How will this impact on the treatment and diagnosis of patients?
Diagnosis, for sure, is going to be revolutionized, because currently, as I explained earlier, we just don't have a way of accurately diagnosing these patients. So clearly it will be the first enabler of that. As far as how it would affect the treatment, there's a clinical situation that I unfortunately was faced with a couple years ago. I think it illustrates the point best. A patient of mine was 27 years old at the time, and she was engaged to be married, and actually was shopping to make her wedding arrangements, and actually was visiting the bridal storeroom to shop for wedding gowns and such. And the fitter actually noticed that there seemed to be a slight prominence in one side of the breast, and pointed that out to her and suggested you might want to have your doctor take a look at it. And she followed up on that advice, and sure enough, unfortunately was diagnosed with breast cancer, but many people are. She obviously sought care at our center, and obviously cancer patients these days are taken care of by a team, in a team approach, and I play a role on one such team as the surgeon. She was found to have one tumor, relatively small, uncommon, however, in her age group to get it, but definitely seemed curable. Was recommended to have surgery. And based on some other reasons, even though she really didn't need very aggressive therapy, she chose to have mastectomy surgery, or complete removal of the breast tissue. Customary for patients that undergo that type of surgery to stay in the hospital overnight. And once we're sure they're doing well, then we let them go home the next day. So I was checking on her the next morning, and the nurse came up to me and pointed out that she'd been complaining of some visual changes. And I said, well, perhaps it's the anesthesia, hasn't worn off yet. So we went to examine her. She was otherwise feeling very well, no other issues from the surgery. But again, confirmed that in fact she felt like she couldn't see clearly through one eye. And on examination, there was a distinct change in the size of her pupil on one side. There's very few things that can lead to something like that so abruptly. Our first thought that was perhaps it was as unlikely as it is, perhaps a mini stroke that she had suffered. And obviously this prompts in the medical world a brain scan with a CT scan. Well, the result of that CT scan was very startling. What it revealed is that we had completely missed the fact that her cancer actually had already undergone metastasis to the brain. And we had no clue of that until she manifested with this symptom of visual change. So overnight, her staging changed from stage 1 to stage 4. Overnight, her prognosis went from excellent chance at cure to impossible to cure her. And we obviously have very aggressive treatment regimens that we could offer her at that point. But I think this illustrates how, because we could not diagnose her earlier when she first came to us, we essentially couldn't act for the month that it took to get her into surgery. And this is the void, among other things, that this kind of testing would prevent. Because we would know from the very beginning, as soon as the biopsy is done, whether we're really facing this or a similar type of aggressive biology situation, in which case the correct thing to do is probably to intervene with aggressive chemotherapy, sometimes up front, even before surgery. But there were no other clinical reasons to suspect otherwise. This is why we feel this will be such a powerful tool for oncologists in general.
How ultimately will this benefit the patient?
Obviously, to the person diagnosed with this type of cancer and to their families, immense benefit, because definitely will be improving their prognosis and chance at a cure. If we try to assess the benefit of this in terms of the total number of people that we see be affected by this type of breast cancer, up to from anywhere from 15 to 45% of the population that is diagnosed with breast cancer may actually have this subtype. And the reason for the variation has to do with racial and ethnic profiles. Unfortunately, some races and ethnicities manifest this type more often, and there's genetic reasons for that. For example, the African American population incidence is much higher. It's more in the 30 to 35% range. And those who are of African descent from the African subcontinent, they can harbor an incidence as high as 45%. So it does vary. And so, but that's a huge fraction to deal with. And so the impact that simply testing with this kit would allow is tremendous in our opinion, because all of these patients, we find out that they have this entity currently when it's too late. We don't realize that they had this at the time of diagnosis until they're manifesting with an aggressive metastasis that doesn't make sense until we backtrack and think, oh, that means she had this all along and we missed this diagnosis. This test will allow us to not miss this diagnosis.
Will the Avisio kit be made available to patients as standard?
Yes, that is our intention, to make the test kit available as standard. Based on the development and progress already made in at 3N Diagnostics and Onconostic Technologies, we are on schedule to really obtain a CE mark designation and approval for clinical marketing as early as 2016, first quarter. With that approval, it would really enable us to make the test available on the market, allow pathologists to run this test in their own laboratories using platforms and techniques that are already very familiar to them, so there's no delay in uptake of the technology as such. And really will allow diagnosing patients with basal-like breast cancer in 2016. The other aspect of a test result, meaning someone's tissue is tested and the pathologist actually finds that, yes, indeed, this tumor overexpresses this gene, FOXY1. It's not just a plus and minus answer. The test allows us to understand how much FOXY1 is this person's tumor actually expressing. And we know from all the data that we have already generated, it actually matters how much. Obviously, it matters if it's there at all. But after we know it's present or positive in the tissue, it matters very much so how strongly is that tissue expressing the FOXY1. Quantitatively, it matters and is directly correlated to how aggressive a clinical course that patient will have. If left untreated, how long will that patient survive? If metastases are predicted to develop, how soon might they arise? In fact, the predictive ability extends so far as to allow us to know if it is going to metastasize and recur, which organ is it most likely to recur in? These are very important predictive features, prognostic features, that empowers a clinician taking care of patients such as this to plan the ongoing care of that patient. Obviously to be aggressive with offering chemotherapeutic options, but also tailoring the surveillance and monitoring of this patient so that if unfortunately they do manifest with a metastasis in a certain organ, there's no delay in detecting it because the imaging and other tests that they would have already been doing for the patient are geared towards detecting the recurrence in that organ, as opposed to a body-wide approach that actually can be very expensive and waste time.
And if people are watching this and perhaps they want access to the kit or even just more information, what can they do?
They can certainly contact the company directly through its website and other contact sources, but I would definitely encourage them to contact their treating clinician, oncologist, who also will be very much knowledgeable about the test and will probably be able to advise the patient best as to whether the test is applicable to them, what does it mean if they test positive or negative for it, and if they do, what is the best thing to do about it in that situation.